Bridging Gaps Through Joint University Practice Appointments is our episode topic. My guest is Dr. Amanda Kirkpatrick, a fellow in the American Academy of Nursing, the Criss Beirne Endowed Professor, and Associate Dean for Research and Innovation, a joint appointment by CHI Health and the Creighton University College of Nursing. Mandy assumed this newly created position in June of 2024. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Mandy, thank you so much for joining us today.
Thank you. Thanks for having me, Nick.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
Like you, Nick, I am an alum of Creighton University, which is in Omaha, Nebraska. So I got my baccalaureate degree here, and then I went on to work in a burn unit before moving into a staff education role. I knew early on that I wanted to teach, and so started my master's degree, got into that staff education role at the hospital. And ultimately, when I got my master's degree, I came back to Creighton as home for me. So little bit of a shameless plug. Creighton has been my home now for 13 years as a faculty educator. Like I said, I started with my master's degree in this role, but I was hired onto a tenure track position, which meant getting the doctorate. And I will say that while doctoral nursing degree isn't necessarily something that everyone aspires to, and to be honest with you, when I took this job, it wasn't something I was thinking about immediately because I was like, I just got through that master's degree. And so I was happy to be done. But I am so glad that I went back. And so if anybody's thinking about it, like just not sure, do I go for the doctorate? Do it. And if you're thinking, I'm not quite sure which doctorate, but PhD might be on the list, do it. I will say we're talking about today that bridge between academia and practice and translating research to practice. And as PhD nurses, we not only serve as faculty, but they're crucial in roles across the spectrum of healthcare. So that can include hospitals, it can include professional organizations, health policy, industry. And I am a researcher, but I will say that this data is mostly my one-on-one interactions with faculty or other nurses who have PhDs, but I haven't heard any of them say that they regret making that choice for their doctoral degree. So we need doctorally prepared nurses, and we really need PhDs. Less than 2% of the population is PhD prepared, and less than 1% of our nurses are. So we need more of those to be infused into the workforce.
This episode is the continuation of a series of previous episodes discussing academic practice partnerships. In Season 3, Episode 8, Dr. Jerry Mansfield discussed aligning practice education and regulatory nursing leaders. And then in Season 3, Episode 9, Dr. Linda Zeman discussed academic practice partnerships at the specialty level, more specifically as an entry to practice recruiting retention mechanism. You were recently appointed to a newly created joint position shared between CHI Health and Creighton University College of Nursing. What's the background story behind the creation of this role?
Like I said, I'd been here at Creighton for going on 13 years, and the person who was in this role, so the Associate Dean for Research was the title before I came into this role. It's now Associate Dean for Research and Innovation. But the Associate Dean for Research was retiring, who, by the way, retired at the age of 80. So if that tells you anything about how fantastic this role is. But in her retirement, she was meeting with the dean and talking about what she sees as the future of this role. And she really had some challenges that she faced in building connections with our clinical partners, which is really critically important for being able to get into clinical sites for research and to get funding. And These just all were really challenges. And even though we had a clinical partner, there was just not a great, I think, mutual relationship there. And so she had suggested that the future of this role be a joint appointment and that perhaps that would demonstrate a shared investment. And that's exactly what the dean pursued. There was a new dean actually coming into this role at the time that the ADR was retiring. And so she was building a new relationship with the CNO, with our clinical partner, CHI, and they struck up a really strong friendship and lots of shared interests in doing this. And ultimately, the CNO invested in a 20% appointment. So he pays for, or the CHI pays for 20% of my time, so a day a week, to be able to really help build those bridges and those connections. And really, there's literature support for this. Employing PhD prepared nurses across academic and practice, these joint appointments is a really powerful strategy to foster research collaboration.
And so you mentioned collaboration is one of the goals, but being more specific, what are the specific goals of this joint role and what outcomes are you responsible for and how are those measured?
So we can really think about the goals on both sides of the fence, right? Or both sides of the street. So on the health system side, I would say one is setting an example for research and evidence-based practice and quality improvement, which are three different, distinct yet related things. Having a PhD nurse and an associate dean for research, they're present in the hospital really elevates the visibility of nursing science and nursing research, the value that we place on evidence-based practice and nursing research, and really even, I think, fostering approachability of PhD nurses, because I'm not the only one. There's several PhD prepared nurses in roles within that institution. And I think that this just brings up some solidarity and some approachability to that. In terms of outcomes with that, I would say daily connections with nurse leaders and bedside staff. So building those relationships. How many connections am I making? How visible am I? I'm not going to be sitting at Creighton's office. I've got a physical office there at CHI where I'm present. I'm spending time in committee meetings and connecting with staff nurses and directors. And another goal there on the health system side is that I said those three distinct things, being able to distinguish between evidence-based practice, quality improvement, and research. That's something that often those words are used synonymously, and that really causes a lot of confusion among our nursing staff. And so I think one of the goals is to develop some formal education programs for nurses to really understand those distinguishable areas of scholarship and some measurable outcomes for that application and enrollment in those workshops, those formal education program, higher levels of nursing knowledge and understanding, and their attitudes towards evidence-based practice, quality improvement, and research. Accessing research and expertise and resources is really needed on the health system side, and really engaging not only these nurses in not only workshops that clarify those differences in education, but also how do you write an abstract for presentation? How do you write, really leveraging the academic know-how with our faculty and myself to be able to mentor nurses in the development of project proposals, in writing for scholarship. Those outcomes would be authorship and peer-reviewed manuscripts by clinical nurses and presentations on the national scale. Enhancing professional development and scholarly activities among health system nurses. That's really a big goal of the CNO here. He really wants to see these nurses advance and be recognized for the work they're doing. So that would include increasing their access to library resources. Are they accessing the scientific literature to really understand what is driving the practices that they're putting in or that they're implementing at the bedside every day? And what we're starting to see, which is a phenomenal outcome, is the submission of more nurse-initiated proposals, evidence-based practice or QI projects. Some research, but those are mostly driven by our faculty. The number of nurses who are pursuing clinical ladder bonuses. So there's a clinical ladder at CHI, and part of what's built into that clinical ladder is participation in scholarship. And really, when nurses become engaged in evidence-based practice, the literature shows that they have greater job satisfaction and retention. And those are some of the outcomes that we're really looking at on that side. And then, of course, I can't fail to mention the translation of evidence into practice to actually impact patient safety and quality of care. Of course, hopeful that the outcomes would include patient satisfaction, looking at those NDNQI indicators and readmission. And this is a hospital system where some of those hospitals are seeking magnet designation. And so hopefully magnet eligibility and actually achieving magnet status. I think those are all things that are goals of and potential outcomes that could be measured from this joint partnership on that health system.
There are many health systems right now where nurses do not have access to information. They don't have access to research databases, particularly some health systems that are not affiliated with academic medical centers or academic institutions. I'm curious, if I was a nurse working at CHI Health, but not affiliated with Creighton University, what access to information do I have when I'm trying to solve a clinical question or I'm trying to look at the evidence that is out there?
To be honest with you, before this joint appointment, there was already that clinical academic partnership. So at
Awesome.
CHI, they've had the access to our library resources as clinical nurses. But I don't know how well known that is or how if they know how to go about accessing those resources. So I think there's just a greater with this role, greater know-how and in knowing that's available. Also, CHI is a part of a big health system, Common Spirit Health, that does also have national resources. So there's other clinical affiliations that some of the hospitals within the system have. And so they may be gaining access to resources that way. Otherwise, they may be, yeah, unfortunately for hospitals outside of the CHI health system, I imagine that they may be relying on open access resources, which
Yeah,
is
which
a
significantly
challenge.
limits some of the availability to what's out there.
Yeah.
How do you spend your time? You talked earlier, 20% of your time or 20% of your FTE is attributed to CHI, and you've got one day a week or an office that's there at CHI as opposed to on the university campus. But what's a typical day look like for someone that's in this joint role?
Like I said, 20% one day. And so I take that very literally. So when I started this position, which again, this was new, I'm forming this. So please keep that in mind. I've only been in this role for 6 months. So I'm learning as I go. But here's what I've learned and here's what my day looks like so far. I've reserved Wednesdays. So I blocked Wednesdays on my academic calendar. So no one at Creighton University can request a meeting with me on those days unless they email me. But they'll see that I'm unavailable on Wednesdays because I really want to honor that commitment in this joint appointment. And so on Wednesdays, I have a physical office at one of the hospitals within the CHI health system. Now, this is technically a regional appointment. So I've started by building those connections with that hospital where my office is just to really understand the unit level, like organizational structure, what resources they have, what the challenges are at that unit, and in the hopes that what I learn and build and propose in this role at that site could be replicated and used across the region and other hospitals. So on Wednesdays, I might start my day with a little session on idea generation. And so every Wednesday morning, the first thing I do is I meet with the professional practice coordinator, who office is very near to me. And we talk about what's happened over the past week in terms of the visits that she's had in mentoring nurses in their project. There are nurses who are developing their QI project proposals. And so we talk about those QI project proposals. Is there an opportunity for faculty mentorship? Maybe a faculty who knows a lot about that topical area to be connected with them. I mentioned one of the goals is to develop an educational program. So we talk about that, brainstorm about what this educational program is going to look like. Is it once a month for how long, how many sessions? And so that's some brainstorming that we do. And then another thing that we're really talking about is enhancing the nurse residency program, because we definitely want to have an educational program for our bedside nurses who are experienced, maybe just haven't had. It's been a while since they've been in school, still lacking clarity on those differences between EVP, QI. But also with the nurse residency program, there are opportunities they do in their nurse residency program a sort of a project proposal. They do a lit review and then they propose what a solution might be to a clinical problem. But they don't implement it as part of the nurse residency program. And oftentimes those proposals sit after the nurse resident graduates, the project is proposed and it sits and it doesn't go anywhere. And so we really want to work on enhancing that nurse residency program to set that nurse up to be able to implement as soon as they graduate and talk about that clinical ladder opportunity. Hey, you've already developed this project proposal. It's awesome. let's go ahead and earn you that bonus at the end of next year by implementing this. And so we're talking about ways we can engage in it. So that's the beginning of my day, is a lot of like brainstorming and wrapping our minds around the work that we're going to do. And then, of course, mentorship. So I sit in on their shared governance meetings. That's actually why I picked Wednesdays. Wednesdays is shared governance meetings once a month at the hospital level. And so I sit in on those practice council meetings as well as their research and evidence-based practice committee meetings. And that really helps me to understand what are the problems at this hospital level, what are the challenges that the nurses are seeing. And then I can also talk through some of the project proposal system level things and maybe provide some advice around their maybe developing a measure to evaluate something new that they've done. And I can just help them fine tune the survey that they're using to get the data that they want. I also have been mentoring and writing. So I was, as soon into taking this role, I had a conversation with some of the nurse scientists at the national level, and we facilitate now some writing workshops. And so it's really been an honor to be invited to be a facilitator in those writing workshops. And from that, I've made connections with some of the clinical nurses that are hoping to publish within the next year. And so I'm doing some one-on-one meetings with them. So a lot of mentorship. Connections huge in this role. So I then spend my afternoon meeting with nursing directors on the unit because I really want to understand their challenges and needs, because there may be students at Creighton or nursing faculty at Creighton that are looking for a project that they can help to address those things. I also sit on like NDNQI committee meetings around falls or hospital acquired pressure ulcers. I'll sit in on some of those committee meetings just to hear the latest and greatest on what those rates are and what the challenges are that they're having, as well as sitting on our regional level and national level evidence-based practice committees. So then I really understand, again, I've been doing this unit level investigation, but then also being able to view that from the regional and national perspective on what's late breaking in terms of resources for nurses and programming that they're developing. And then it's time to take action. From all of that information, I'll make email introductions to our faculty to help build teams. I'll review proposals for projects, provide feedback, and then we've even written some grant applications, having some collaborative faculty and practice side collaborations on grants that have been submitted. So it's been a lot of busy and exciting work.
You talked earlier about the QI projects and how some of them just stall. They don't go to that next step. And it made me think a little bit also about some doctoral scholarly work, particularly on the DMP environment, where that information sometimes just stops right at graduation. And a lot of people don't take the next step to disseminate their findings through publication. Yes, they present it, but they're not publishing it to get it out there. How do we bridge that gap and break that down a little bit better? Is there a greater solution to that at a more broader level where when people are finishing their work, they submit it and take that next step to publish? Why is everyone not required to do that? I guess would be my question.
Yeah. The why is a big question. And I don't know if I have an answer to the why other than it varies. Their requirements vary program to program. As I said, I'm PhD prepared. And so one of the requirements of our program was that we submit. And while we weren't required to be published because you have little control over whether or not a
Sure.
journal accepts your manuscript, you did have to submit. And the other thing that the PhD did that might be different from the DNP is there's these chapters, and for some PhD programs, they offer an alternate format dissertation, which is you could actually write multiple manuscripts in place of chapters, which is something I did. I actually wrote 2 manuscripts for my chapter 2. I did an integrative review, like a systematic review of quantitative and qualitative research in my area. I did a concept analysis, and I submitted and published both of those. And then for chapter 5, which is the results of my dissertation, I also had 2 manuscripts. And so I think that building that into the academic program is really the solution. I will say at Creighton, we have a number of DNP tracks. And while our students are not required to submit for publication, they are required to disseminate beyond Creighton University and beyond their champions. They can't just present at our student forum or at their hospital. They have to submit and present maybe at a regional or national conference or submit for publication. And so there is that. The other thing is that, again, still students may not pursue the publication because it's intimidating. the faculty communicate with the student that at the point that you've completed your project, if you decide that you don't want to pursue publication, I may still pursue that. You would still be first author on this publication, but the faculty could actually, on the behalf of the student, pursue that publication. And to be quite honest with you, Nick, it's hard to say that every DNP project is publishable.
Oh,
It's
sure.
you right? And
Yeah.
so I think that would be a barrier too, like to actually say that a DNP project had to be published or even submitted for publication would be challenging because and then that would put a lot of burden on journals to review manuscripts and I don't want to say I hate to say mediocre, but maybe projects that aren't publishable. But if you require a student to submit, then it's incumbent on the journal to at least review, maybe not read the entire thing, but have to make some decision about whether or not they're going to accept that manuscript.
Yeah, that's fair. On the flip side, though, a lot of journals have moved more to this screening approach before they even submit things for peer review. And many manuscripts have a first decision within 3 or 4 days because it's just a reject. It's do you get through to peer review and get that process, or is it just flat out rejection? Interested in trying to understand, can you provide, and maybe it's a little too early in your new role to have some successes, but wondering an example where the existence of this role, this joint role, has aided HI health, where it's aided Creighton University, and ultimately the patient that we're all here to serve.
Absolutely. I know, happy to share some of what we've done so far. I didn't get to speak much to that academic side, but I will say that some of the things that we've definitely made progress on is building those connections, forthright, that those collaborations are so important to bridge that gap. And so we've built connections between faculty and nurse leaders on mutual topics of interest to really build up projects. One example of that is there was an opportunity that actually the VP of the hospital where my office is located really was interested in doing some programming for his nurse leaders, like his directors and managers. And so we have a DNP in leadership at Creighton University. So I said, I know the perfect faculty to collaborate with you to do some leadership development programming. And so that's been one of the very first successes was connecting the two of them. And they've already had one session and they're planning out actually a 6 month entire like monthly program from start to finish, where they'll do some review a book and do some other things there. And they're, of course, in the for the sake of scholarship, going to evaluate the outcomes of that programming as well. So that's been one huge thing. Another thing on that CHI has benefited from, one of actually the first things I did in this role was the call for the American Academy of Nursing's Edge Runner Awards was out, the call for submissions. CHI has this awesome virtually integrated care model. They were one of the first virtual care models, and their care model is unique in virtual nursing. And I said, people need to know about this. You need to consider applying for this Edge Runner Award. So I worked with the nurse leaders of the virtually integrated care unit in developing and writing that Edge Runner application. And they were ultimately recognized and awarded, which is huge for an organization to receive the Edge Runner, to receive that level of recognition. So that's been huge. And I don't know. I think that certainly they were deserving. But the piece that was so helpful is that academic perspective in writing a winning application, I think. I not to boast but I'm boasting. You asked me to. You said, what have I accomplished? And now I'm sharing it.
It's fine. Yeah.
Yeah.
Having a good writer is so important. You think about the magnet designations and who gets magnet and who doesn't, and a lot of other applications. For a period of time when I was on the board for the Academy of Emergency Nursing, we're reviewing the applications for those that are trying to be fellows and decide who gets in and who doesn't. And it's not sometimes that what we're reading is not necessarily worthy, but it's not translating on the paper the way it needs to for that recognition to exist. And so you've got to have a great writer to tell the story.
Yeah, you're absolutely right. We've had similar situations here with nominations of faculty for awards. And that's why I think it's really the responsibility of someone in my role as Associate Dean of Research to really help with, yeah, mentoring those faculty along. And for all of us as experienced writers, as faculty, to work with these clinical nurses across the street and helping to achieve those goals. And ultimately, we're making this is really helpful for our faculty because as faculty and in academia, our promotion structure is built around doing scholarship. In order to
Absolutely.
achieve tenure and promotion, we have to publish. And joint publications are awesome because you're really, again, like you said, it's so important that we're publishing the great work that we're doing. Clinical nurses are doing great work. We just need somebody to be able to read about it. And so that's where our faculty are benefiting because they're getting that publication, and the clinical nurses are benefiting because they're getting to see that their work get out there and be celebrated. I think this has been an opportunity for increased grant submissions. We've seen an increase in our grant submissions by building these partnerships. And I think that's going to ultimately, although it's not happened yet, one of the big things that we're aiming for is extramural funding. That's always huge in terms of colleges of nursing, but universities as a whole, looking for federal funding for research projects. And I think in having a strong clinical partnership, it really puts us in the running for some of those awards. So that would be, I would say, some of how our Creighton has benefited, as well as adding that accessibility to the clinical site for these research studies, including student projects, which can sometimes be a challenge because there is a competing demand among our colleges of nursing in the area for student placements and being able to be mentored in and do some projects with those hospital and, those institutions. So, and then, again, it's still pretty early on. So in terms of patient outcomes, I would say, like I said, we're increasing the number of proposals, both clinical nurse initiated quality improvement and evidence-based practice proposals. And we're improving the quality of those proposals and really the excitement. There's a lot of excitement building around this enhancement of the nurse residency program and what that could do, and this new programming to help our clinical nurses understand the difference between evidence-based practice and QI and helping them write those proposals and really start to implement. And I want to go back to our faculty benefiting because they're now able, when in doing these partnerships, they can address real world and relevant clinical needs. They really can understand faculty need to maintain clinical skills and stay current on practice issues because that translates back to the classroom and it enriches the students' learning. And that there's just this opportunity for increasing these practice ready nurses, the pipeline for local employment as well. This is a great recruitment opportunity for our CHI partners, graduating more practice ready nurses and faster implementation of EBP. And so ultimately that will translate to quality patient outcomes, I think.
It sounds like you have a really fun role where you get to be the connector, the networker. If I'm at a cocktail party, I can picture you the person of grabbing the person from academia and grabbing the person from the hospital and putting them together and then stepping away and letting them figure things out. That sounds like a really exciting opportunity and watch people thrive along the way. Are there any closing thoughts that you have as we wrap up this episode?
Yeah, you're right. This has been fun, but it hasn't been easy. And for those who are thinking about building these types of partnerships, which I would highly encourage, one thing to consider, these roles exist, right? My experience or those that I've met that are in these types of joint appointed roles, they aren't necessarily in the role that I'm in. I'm the Associate Dean for Research and Innovation within the College of Nursing. And what's unique about that perspective is that I know my faculty, I know their scholarly interests, I know their strengths. I also know our curriculum. So we get some feedback from our clinical partners on in what ways are our nursing students not ready for practice or what are those new challenges. And so that can be fed back into improving our curriculum. But it really is, if you're going to build an appointment like this, it takes mutual commitment and funding of these roles is critical. As I said, my predecessor really tried to do this work. Just in having a clinical academic partnership isn't enough. The joint appointment and putting the money where your mouth is really builds that investment and the likelihood of success for these types of relationships. I think I'd like to just mention the importance of leveraging shared governance structure and the clinical ladder to really help infuse excitement and incentivize the engagement in evidence-based practice in QI. That's also a way that we can identify those research priorities is just really engaging with the shared governance structure to know and see. And then having those specific pathways and incentives to engage the nurses is so important. And I want to do a huge call out to any nurse that is in a coordinator role and like professional practice coordinator, nursing practice coordinator, magnet coordinators, like they call them by all the different names, but they are all doing the same thing. And they are essentially the lifeblood of evidence-based practice. We need to value and leverage them. They really need support of their leaders and their hospital systems to be able to be empowered to lead and to do the mentoring and the hard work that they need to do to really bring along these nurses and getting them engaged in evidence-based practice. I could go on and on.
Bridging gaps through joint university practice appointments has been our episode topic. Dr. Amanda Kirkpatrick. That is a tongue twister.
It is. I still screw it up.
Wow. Well,
I married into it.
thank you very much for your time today. Appreciate it.
Yes, thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.